even with the best attempts of using such plugs in your ears, sometimes water still can seep in, and it can lead to otitis externa. And when it's so otitis externa is an umbrella term. The word otitis means ear infection, and externa is the location. So externa means the external part of the ear, so the outer ear. Otitis media is an infection of the middle ear. So media makes reference to the middle ear cavity behind the eardrum. So swimmer's ear is a subsection, if you like, a subvariant of otitis externa. I don't really want to be using that term's variants at the moment for obvious reasons, but you know what I mean. It's an umbrella term, and it encapsulates the term swimmer's ear, and the swimmer's ear is otitis externa. It's an outer ear infection caused by water in your ear, typically via swimming or showering, for example. If you are a viewer of my channel, you would know that I'm very, very adverse against allowing yourself to get water in your ear. It's the most important advice I can give, that and not poking inside your ear. So the patient's got a lot of otorrhea, so past discharge. They had seen their GP, so saw the patient last week initially, and the ear was completely swollen. It's so hard to get into the ear, but there's a bit of occluding debris that I managed to squeeze in with a fine end to clear it. So the eardrum was visible, but the ear was extremely swollen. Wrote to their GP, prescribed a course of antibiotic spray. I also advised my friend, the patient, to apply some hydrocortisone cream externally, not in the inside part of the ear, just on the concha bulb, the outside, because that was heavily swollen. So they finished the course of antibiotics. They felt their symptoms had improved, but it's still a bit wet in there, they felt. So we had a look and saw this otorrhea. Where I am now in the anterior recess, you would have seen about half a minute ago, I removed a thick piece of skin and also some granulation tissue. So what is granulation tissue? When you've had an infection or some trauma and your body heals, where it's healing, sometimes you get a buildup of connective tissue, and that connective tissue then has its own supply of blood vessels, and we call that a granulation tissue. It's kind of red in appearance, it can be quite bloody because of the blood vessels, it's rough, wet surface, and quite often when we're suctioning granulation tissue, it can actually come off as we're vacuuming. The first time I've removed granulation tissue was accidental. I wasn't sure what it was, and I got really worried. I contacted my good friend, he's an ENT surgeon, Mr. Darish Rajali of Ear and Balance. He's also got a YouTube channel, guys, where you've got loads of middle ear surgery videos you can watch. I showed him the video, and he just reassured me it was just granulation tissue. So I've cleared all the otorrhea, so the occluding pus, debris. I'm just trying to get this dead skin now off the canal wall using a fine end suction probe. It's a very delicate procedure. Obviously the ear is very tender. It's always a bit more, not nerve-wracking. I don't get really nervous anymore when I'm doing the procedure. Obviously at first, when I first started, naturally, like with anything new, you do have a bit of nerves. But whenever you're doing a procedure on someone you know, friend, colleague, family member, it's a bit of added pressure for some reason, can't quite explain it. I know everyone's got high expectations, but more so those nearest to you. And it would be quite ironic if you were to accidentally injure or harm one of your friends or colleagues or family members, as I mentioned. So just being very gentle, as I always am, I'd like to think. And you're just going to watch me peel all this away. Now, this is the first appointment. So, as I said, the patient came, second appointment. Initially saw them a week ago. The ear was completely swollen. The doctor actually couldn't look in the ear. So when I wrote to the doctor, the patient went so they can get some antibiotic spray. The doctor wasn't actually able to examine inside the ear. I was just about to get in with the endoscope so I could see, but it was so swollen. And the main key bit was we just wanted to confirm there's no perforation, because if there was a hole of the eardrum, then that would impact the medication prescribed by the GP. A lot of antibiotic sprays and drops for the ear, they're what we call ototoxic. They contain what we call an aminoglycoside. And what an aminoglycoside are, they're medicines typically ending in mycin, so gentamicin, neomycin, erythromycin, streptomycin. So those drugs ending in mycin, so either MICIN or MYCIN, they're typically ototoxic, and if they enter your middle ear through a hole in the eardrum and they go towards the inner ear where the organ of hearing and balance is, it can potentially cause permanent hearing loss. So the key bit was to make sure the patient didn't have a hole in the eardrum, so the doctor could prescribe the appropriate medication. There are some medication that you can use for perforated eardrums, but typically there's the certain ones that GPs like to prescribe. In the UK, Otomize is the main one, I would say, and that contains neomycin, dexamethasone, which is a steroid, reduces inflammation, and acetic acid. So acetic acid is designed to reacidify the ear, and that's very important with ear infections because your natural pH of the ear is slightly acidic. When you've got an ear infection, the pH of your ear goes past neutral, past 7, into the alkaline range. So the acetic acid is designed to reacidify your ear, and that helps inhibit bacterial growth. So they've used it for a week. Typically, if it's purely a bacterial ear infection, that would more or less nip it in the bud, but obviously it hasn't. So this is the second appointment. I'm just mopping everything up, clearing it up. We get as much out as possible. There is a bit of dead skin, if you keep watching, that despite my best attempts, I wasn't able to peel it off the eardrum. Or I should actually rephrase that and say I couldn't get all of it off the eardrum. I did get some off the eardrum. Nonetheless, the patient's symptoms are significantly improved. They could hear 100% after we finished. And I was hoping, like, if they had a bit of antibiotic spray left, I want to use it, because I know some doctors can use up to 10 days. So just to finish that off, and hopefully that will nip it in the bud now that I've got all this debris out. Unfortunately, so patient saw the patient again today. And although they was much better, and you'll see this second part, so if you keep watching, this is from yesterday or the day before, and a bit later on in this video you're going to see how the ear was today. So it gives you an idea of when someone's got an ear infection, we clear it, sometimes the infection can come back, because when we're suctioning the ear, we're not necessarily killing the bacteria. Well, in fact, we're not killing the bacteria. What we're doing is clearing the canal of any pus, dead skin, debris secreted by the infection, which is a byproduct of the infection. But the bacteria is still there, so that you still need to use the prescribed medication. And often when you clean the ear, the medication that you're prescribed has a better chance of taking effect because it can make direct contact with the canal wall where the bacteria probably is, and most likely is. Now, I'm just trying to use any types of drops because patient, when they've got an ear infection already, I want to keep the ears dry as possible, just allow the patient to use the medication they're prescribed by their GP with. I did use a bit of olive oil just in the end because this skin on the eardrum is very crystallized, very thick, almost like a shard of glass or some sharp dried plastic. So we, as I said, we cleared the debris out. I'm just trying to get some of these remnants now off the eardrum. You can see me on the eardrum there. I'm just peeling this away. It's quite tough and stubborn. I think about this stage or a bit later, the patient did develop the caloric effect. What is the caloric effect? Each ear in the inner ear has what we call the vestibular system, the vestibular organ. The term vestibular refers to your balance, and it's actually connected to the organ of hearing, which is called the cochlea. And the organ of balance is composed of 3 membranous, hollow, semicircular canals, and these little semicircles, loops, you've got one posterior going to the back, one lateral or known as horizontal towards the front, which is in a horizontal plane, and one superior. And so these, in combination, these 3 loops, semicircular canals, it's full of hair cells, just like the organ of hearing. It is fluid. And depending upon your head movement or body movement, fluid moves in certain directions in each of these 3 semicircular canals, and the brain then receives different messages from both ears, from each semicircular canal, and it's then able to orientate and have a sense of your position in the real world and the environment that surrounds you. And the organ of balance can be affected not only by pressure, but also temperature. So if you're sat still, as this patient was on a chair, looking straight ahead, the brain is receiving equal messages from both organs of balance. And that tells the brain that you're stationary. Now, when we perform microsuction like we are now, it reduces the temperature in the ear. Now, of course, we're not performing microsuction in both ears at the same time. So this is the patient's left ear, therefore the temperature in the left ear is below the temperature in the right ear. And when we reduce the temperature in the ear, it almost inhibits the function of the organ of balance. Conversely, if you increase the temperature or the pressure, it can excite and overstimulate the organ of balance. So in this case, we're inhibiting the organ of balance. Therefore, the left ear is sending less signals to the brain than the right ear, which then tricks the brain. It fools the brain into thinking you're moving to the right, but you're not. You're sat still. So then the eyes get confused and your eyes jump in trying to correct your brain. And during that time, you develop vertigo and your eyes can rotate and spin. And it typically lasts a minute or so until the ear comes back to room temperature and then it settles down. But during that time, people can faint. They can become viciously sick or nauseous. So the patient did experience a caloric effect, and it typically happens when we're working close to the eardrum, where obviously it's more sensitive to temperature change. So you probably saw there, I just went in with some fine jaw crocodile forceps to help me detach that dried skin that was on the roof of the ear canal and on the anterior canal wall. The patient has got a very, very narrow ear canal. There's no more inflammation or swelling there, that's gone. Just naturally the ear is very, very narrow. So there's a limited space in there, but we're just trying to peel this off the eardrum now. Patient can hear significantly better despite this bit of hard crusted skin. The eardrum's now visible, sound can get through, there's no discharge there or occlusion. So they're hearing significantly better, but I just want to get as much of this out as possible. Now you're just going to watch me do this for a couple more minutes, I believe, until you'll see today's video. And whilst you are, I am just going to answer some questions from yesterday. There was a question about a blue plunger. Why didn't I use that? And I hadn't a foggiest of what they were referring to. And then some people commented yesterday about what it was. So that blue spiral device is called the Earwax Pro. It's developed by a Middle East company. I think they're from Israel. And they approached me back in 2016, or could it be 17? And they actually flew over to the UK to see me. They wanted me to become, to endorse their product basically, because if I can endorse it, publicise it, they're going to get a lot of sales. And I was working with them for a while. I did use it. So if you go to video 486, you'll see it in action there. Now, I don't use that device anymore. I did only use it a limited amount of time. That device, it'll only work if the wax is really near the entrance. So in the first bend, first centimetre. Anything beyond that, it's, despite what's been said, it can come in contact with the canal wall. It can be a bit uncomfortable. And for me, it's a bit of a blind technique still, because you can't really see what you're doing. And people come to see me because they want me to remove stuff under direct visualization. I'll come back to the moment. So you can see I just put some oil in here just to soften that skin. So the ear canal looks really good. It's just some dead skin just around the edge, nothing significant, but I'm just going to mop up some of this oil. Now I do try and peel some of the skin off, you'll see, but it just wasn't ready to come off even with the drops. I'm peeling it. I think the patient got slightly dizzy as well at this stage. And sometimes we just have to accept this is not going to come off. We can't overforce it. Someone's eardrum, we don't want to perforate it. We did our best, softened it as well. But if you stay tuned, you'll see today's video and you'll see that I actually removed that. So yeah, going back to Earwax Pro very quickly. It's a helix device, and the idea is you twist it and turn it in someone's ear. It envelopes itself around the skin plug, and then you can slowly remove it. So if you watched that video yesterday or the one before, then I think that's where the comment was reflected to. This wax was on the eardrum. It was in the anterior recess. There's no way that Earwax Pro is going to get into that deep and remove it. It's going to hurt the patient. It's going to be really, really painful. So do I use the Earwax Pro? No. They have been in contact a few times trying to get my endorsement. There was a time where I did say that it has got some efficacy under certain patients, certain types of wax. But for example, a procedure like this, it's not going to work. And looking at some of their data that they give, and they'll obviously defend the data, but they were saying it's 80% successful. And I just, in 80% of my cases, I wouldn't be able to use that device. So I fail to see how it can be 80% successful when I could only probably use it in 20% of my cases. I see at least, and obviously I do see a bit more complex cases than not. So I hope that answers that. So this is today's same patient. They've come. So saw them yesterday, cleared all that ear out. You can see it was a lot better, but this discharge, the bacteria is still there. As I mentioned, when we clean the ear, it doesn't kill the bacteria. So we're just on the anterior medial canal wall. This is the narrowing near the eardrum. It's this region where the patient's got this thick skin that develops. And again, some granulation tissue. And you'll see me just peel this off. I got all the outer ear off the base of the ear canal. And as you continue to watch, all that debris on the eardrum, which is just dead skin, I managed to peel it all away. Someone also asked, was there a hole in the patient's eardrum yesterday? They saw a black hole. No, that's just dead skin, keratin, like it's on this eardrum here. So that really wouldn't really affect the patient. Again, that was just little spots yesterday. It was just dead skin that's oxidized. It wasn't a hole in the eardrum at all. So typically you can leave that. It's not going to cause a problem. In this particular case, I managed to remove it. Did I have to? Probably not, but felt comfortable. Patient was still. So we managed to do it in the end. It's important to remember, as a clinical ear care specialist, we're not trying to remove every little last speck of wax, infection. Where possible, especially if it's infected, wherever possible, I will try. The more debris I get out, the better for the patient in terms of the healing process. But it's not always possible because it's difficult in the ear. Ear's tender as well. And sometimes it's just not going to come out. It's going to potentially cause more trauma, attempting to remove stuff. Than do any benefit. And if it's just wax, a bit of wax it's not infected. Wax is good for you. So you can see me now right on the drum. You can see that this is how good the eye clear scope is, the magnification. We're literally just peeling this off like a stamp off an old stamp off an envelope, just gently revealing the whole eardrum. And then the skin comes from the top. It came out in a big piece, which is really good. Someone wanted to know how to treat blocked eustachian tube. So I appreciate not everyone's watching all my videos, might be new subscribers. I talk about the eustachian tube a lot. It's one of my areas of clinical interest, but depends on the cause of the blockage of eustachian tube, but typically nasal decongestion sprays. In the UK, we have the Otovent nasal balloon. I'm developing my own device that's going to be helping to unblock a eustachian tube. And it's the device called the ear popper. I think there's something else in America called Eustachi, short for eustachian tube. I think I've got that right, Eustachi. Go and see an audiologist, go and see a GP or physician, ENT, just to confirm your diagnosis there. I hope that helps. Someone asked whether they should, asking myself whether they should go and see their doctor after getting some water in the ear and caused a bit of pain. Any cause of concern, guys, please just go and see someone about it. I can't give a clinical advice without seeing the ear. The only advice I can give is if you have got any symptoms and you've got any concerns, please do go and see a doctor about anything, not just about your ears. If there's anything of concern, please get it checked. I don't want to be someone who's online saying, no, don't worry about it, and something happens, and then the fingers get pointed at me. Well, that chap, the wax whisperer, said, oh, it'll be fine. And then it leads to a raising infection. So I can't give any individual clinical advice. Any concerns, please go and see someone local. Ask them to examine your ears. And that's the best thing for you. And also, I don't want to be liable for anything. So I hope you appreciate that and understand. Someone wanted to know whether I offer payment plans. I appreciate it, especially in the UK. I think it's global, inflation's going up, etc. But unfortunately, I don't. We don't offer any payment plans. If you're in the UK, go and see a doctor. They can make a referral to the ENT department. It's a bit of a wait, but please do go and see someone about that. If not private, do go to your doctor. See, we cleared most of that out. I'm just going to mop up all this dead skin. I'm just going to let you watch this whilst I keep answering some more questions. You may have also seen on the outer part of this patient's ear, there's some white cream there. That's a hydrocortisone cream. The patient went a bit OTT with it, and it's in the wrong region. I told him to stop using it now. The swelling's gone on the outer part, so there's no need to continue using that. Again, you can just see we've got a steady hand here. We're going to just peel all this away for the patient. My gut feeling is that the patient possibly may have a fungal infection because it's been quite stubborn against the antibiotic spray. Going to use the Otomyce for a couple more days. Obviously keep looking in the ear and then resort to Canesten antifungal ear drops if required. Another question I keep getting asked about is whether I've trained anyone in the US. Currently, no. We've had a lot of interest, as you can imagine. Just with COVID, it's very difficult. This device, I'm more than happy to sell it to anyone in America, obviously a trained professional, but they're not going to be able to use it unless you're an ENT. It's just going to be too complex. And yes, it's great for me. I can sell loads of devices. We've had loads of interest around the world, guys. Australia, South Africa, every part of the globe, really. But this needs proper training, and it's all good and well me selling a device, but people are going to struggle. Yes, I line my pockets, but it's not all about that. It's about offering the best care. So I've resisted selling this device without the appropriate training. We've had people coming from Canada, for example. Also in America, it's the FDA approval. With COVID, there's less of an opportunity for people to come here from America or me to go to America to train people. And then with the FDA approval, it's a lot of money every year, annual fees. It'll just be a waste at the moment because the demand, although the demand's there, practically it's just not possible to do the training. But let's see what happens in the next year or so. I've definitely got big plans. Someone wanted to know about tinnitus. Tinnitus as a whole, where do we start? It's such a big topic, and it's it's not probably the right platform for me to talk about tinnitus, unfortunately, because there's so much to say in so little time. There's a British Tinnitus Association website where you can learn loads about tinnitus. So do go onto that. You can just Google it, British Tinnitus Association. The acronym's BTA. Someone asked my longest procedure. I can't remember, but I think it's about an hour. It's on my YouTube channel somewhere. The excavation of one man's ear, I believe it was. That was the most lengthiest procedure. So just if you go back to the video, nice healthy ear. That's all clear now. As I said, patient's going to continue to use the antibiotic spray for a couple more days, and if I don't notice an improvement, going to refer back to the GP, ask for an ear swab, and get the patient hopefully onto some Canesten antifungal drops. Someone asked what my ideal tool is to remove wax and dead skin. The ideal tool is the correct tool, whatever that may be. It depends on the consistency of the wax and dead skin, the anatomy of the ear canal, the location of the dead skin. Is it lateral? Is it on the bony part? Is it on the eardrum? So I don't have a preferred tool, or the ideal tool is the best tool for the job, and we don't know that until we're in the ear and we get even if you watch it on YouTube and you think, oh, why didn't you use that tool? It's different to watching it when you're actually with that patient, and the feel, the orientation, the angles of the ear. So it's I hope that kind of answers that in a funny kind of way, but short and simple is the right tool is the ideal tool, whatever that is. I think the same person asked about headphones and earbuds. If you've got headphones, it still allows the wax to naturally migrate. If you wear earbuds, they go in your ear, they can push the wax further in and stop the wax from migrating. Someone wanted to know whether it's expensive for microsuction. Not really. It's a small fee, starter fee, in relation to how much earnings you can get if you're charging privately, or even for primary care. I think it's a nominal fee, really. It's negligible. So yeah, microsuction is more in use in the UK than any other technique. It's a bit more skillful than irrigation, so it needs a bit more training. Just read a complaint. They couldn't watch the rest of the video yesterday. I haven't got a clue what they're going on about. It's probably because you got the video on mute, and after the video's finished, I'm actually spending a lot of my time answering questions, which I don't really have to do. So to that individual, don't get angry. Think about what's going on, and if there's no you did get the whole video. I'm giving this video free of charge. I'm not obliged to, so don't moan. Be grateful, and if you don't like it, don't watch it, but don't begrudge or bemoan me. So sometimes I'm spending 5 minutes on a procedure, but I'm then spending three times more longer answering questions. So a thank you would it go amiss from that individual, sort of bemoaning why there's no video at the end. Well, there is. Unmute your video and listen to the audio. Someone wanted to know why, well, advised me to say a few more, or say some jokes, although to go off topic. So this is meant to be an educational video related to earwax removal, but I've got a great joke. Knock, knock. Who's there? I hope you found that funny. Someone else asked, geez Louise, some of the stuff on YouTube, it's just mind-boggling. Someone wanted to know whether I can advise some home remedies for earwax removal. They're actually thinking of buying their own devices and tools and remove it themselves. Please don't. You're going to do so much damage. Go and see a doctor. I don't know if you're in the UK, but if you are in the UK, we've got the NHS here. Yes, okay, most doctor surgeries don't offer earwax removal anymore, but they can refer you to the NHS. Bit of a wait, but rather be safe than sorry. So please don't do any DIY job. You're potentially making things much, much worse. A really good question from someone: how long does it take for the skin to migrate out of the ear? It varies, everyone's different, but on average, the skin migrates similar rate to your fingernails. I think it's around 3 millimeters a month. So give or take, if your average ear canal is 3 centimeters in distance, dead skin from the center of the eardrum, as it dies and sheds, it will approximately take 10 months for that skin to migrate up the middle of the eardrum, all the way down the ear canal, out of the ear. Brilliant question. That's the kind of questions, as opposed to saying jokes on my videos, that's what I like to answer. Again, someone wanted to know they're below the age of 16, whether I offer free earwax removals. I don't know if it's just me specifically. I'm a private company, so unfortunately we charge for every patient, regardless of the age. So again, if you're in the UK, please do go see a doctor. I know it's difficult, especially given the current climate, but they will be able to refer you to the hospital if they're not able to try an irrigation. So irrigation, I'm not a big fan of with water in the ear, but it's sometimes if you can't afford to go private, you can. I would still recommend irrigation done by a qualified nurse, than trying to do anything yourself. But the doctor can also refer you for microsurgery at the hospital. It might be a bit of a wait. I think that's all the main questions. Someone asked me about a device called Twindler. There's an earwax removal ad. If it's something like that online, Facebook, I don't even need to see it. It's a big no. Anything DIY, guys, stay well aware. So this is the Q&A section, just in case anyone has a go. Why is there no video?